Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Niraj Kalore from United States. Dr. Kalore is Associate Professor of Orthopedics at the Virginia Commonwealth University Health System with special interest in sports medicine and joint reconstruction. After completing his residency in St. G.S. Medical College in Mumbai, Dr. Kalore pursued his adult reconstruction fellowship at the University of Minnesota Medical School in Minneapolis and the sports medicine fellowship at the American Sports Medicine Institute, Birmingham, Alabama, United States. Dr. Kalore serves on the editorial board of Arthroscopy and Knee Surgeons Arthroscopic Association of North America, and he's also a reviewer for several leading journals. He holds a US patent for automated hip analysis methods and devices, which he filed last year. He has published widely in the journals of arthroscopy and arthroplasty and also won several awards, including the Best Poster Award at the American Academy of Orthopedic Surgeons annual meeting. And he's also presented several papers at the AHKS and the Arthroscopic Association North America meetings. So today, it's my great honor to introduce you Dr. Niraj Kalore from the United States. Over to you, Niraj.
Thank you for the kind introduction, Dr. Gopalan. Hi, everybody. I'm Niraj Kalore, like we talked about. I'm going to today talk about a topic that is very dear to my heart. It's about use of technology in total knee arthroplasty. So my goals today are to clarify why we need technology in knee replacement, and then to look at and present some data on what is the current stage of technology utilization in knee replacements, and review how each of the technologies work, what are the benefits and limitations of each of the technologies. So we'll go stepwise here. So before we proceed, the traditional goals of knee replacement are proper soft tissue balance, a proper alignment, and accurate component position and size. And these have been kind of refined over time. But in recent evidence-based and value-based healthcare, two additional goals are logical. One is patient satisfaction. All of our work is nowadays assessed for patient satisfaction and also for cost effectiveness. If you look at it another way, the bottom two are the goals of the society. The top two are the goals of the surgeon. Both are important and both need to go hand in hand. And any of the technologies that we look at, they should meet all of these goals together. Then only they'll be of great value. So total knee replacement is a complex surgery. There are multiple variables that depend on each other, and each one of them needs to be precisely adjusted. Any one of you who has been in multiple knee replacements knows that if one of the cuts goes wrong, if one step of the surgery goes wrong, then it consequently leads to another error, which you try to fix with something else, that leads to something else. And that way, this cascading effect continues, and this can result in poor alignment and inaccurate implantation of knee replacements. The data shows that about 20 to 30% of knee replacements are showing features of inaccurate implantation when looked by multiple criteria. The ultimate effect of all of this may be that patients are not satisfied with this. Currently, about 10 to 20% patients are not fully satisfied with their knee replacements. And some of this may be technical. Now, being human beings, to error is human, so error is going to happen. Our job is to avoid it, contain it, and compensate for it in a proper, measurable way. For this, we need live quantitative feedback during the surgery, and that is where technology comes into picture. No matter how experienced you are going to make some errors in surgery, and we'll see how exactly that happens. But we definitely need some kind of quantitative feedback during surgery so we can avoid inaccurate implantation and have more satisfied patients. Now, before we jump into the actual technologies, let's look back at how exactly we came about doing the knee replacements the way we most often do these days. So the concept is one of mechanical axis and the anatomic axis. The mechanical axis runs from the center of the femoral head, goes all the way down to the center of the ankle joint, uh, is slightly medial to the midline of the tibia. The anatomic axis, these are anatomic axis of the femur and the tibia. The native joint line is about 3 degrees of varus at the proximal tibia and 3 degrees of valgus at the distal femur. Also notice that the femoral shaft is about 6 degrees of valgus to the mechanical axis. So in all, there is 9 degrees of valgus in the femur and 3 degrees of varus in the tibia. So when Dr. Insal designed this knee, he considered the fact that when we use existing jigs, there's about a 3-degree error, which may be in varus or valgus in about 30% of the tibial cuts. Because as you get deep on the medial side, the bone is not as supportive, and that leads to more failures. That was his assumption at that point of time. Later on, some people proved it, but that's how it started. So his premise was that we should cut the tibia perpendicular because our instrumentation can do this reliably. And because we cut the tibia 3-degree perpendicular to the tibial axis, we need to make the femoral cuts at 6 degrees of valgus in relation to the anatomic axis of the femur. That way, both are perpendicular to the bone axis, and the joint line is perpendicular to the mechanical axis. Now, what that also does is, if you look at the flexion gap, because we have over resected the lateral tibia, to make the joint balance, we had to externally rotate the femur 3 degrees. This is how it originally started. Subsequently, it was known that yes, it does help with patellar tracking, various other reasons for doing that, but this is how it originally came about. So notice that the original knee planning or the knee alignment principles were based on what error is there, how accurate can human cuts be. And that's where I think this has changed a lot, where now we can get past this premise of this much error with this much, this percentage of tibial cuts. If we can make precise cuts, we can probably make a precisely oriented knee, what is known as a kinematic knee. So this illustrates the two concepts, the mechanical axis running from the femoral head to the center of the ankle. Then the mechanical alignment where both the components are perpendicular to the mechanical axis. Even though this is most commonly done, this changes the knee in a significant way. A more anatomic alignment, which is nowadays known as kinematic alignment, is where the components are, the femoral component is in 3 degrees of valgus and the tibial component is in 3 degrees of native varus. And this restores the anatomic knee joint line. And many people say that there is less need for balancing with it, but long-term data is still lacking on it. Now, subsequent to Dr. Insal creating his technique, Dr. Berend proved that in his study that if the tibia is in more than 3 degrees of varus, there is increased failure rates. And if the femoral component is in more than 8 degrees of valgus, there is increased failure rate. That was a study by Dr. Bellmans. So notice that the small changes in knee, which are a few degrees, make big changes in the knee kinematics and how things function. What has also changed in the knee, which makes technology necessary, is how balancing has changed. There was this concept of 4 ligament knee, out of which 2 are removed and we just balance the medial and the lateral side. That's the classic stuff. That has changed over time. Now we recognize far more ligaments and balance far more ligaments. It is manually very difficult to assess this, and that's why more technology is needed for more accurate balancing. It is no longer just medial or lateral side. It is nowadays considered in thirds, the anterior third, middle third, and lateral third on each side. And you can release structures on in different locations to balance the knee in a different way. The traditional spacer blocks are completely inadequate to assess that kind of balancing. That really requires an actual measured sensor that can tell you which side is tighter. I mean, of course, we still do it manually, but I think those days are numbered. Again, look at this paper where they made small changes in the knee and used a sensor to measure what is the difference in the pressures in the compartments. Their conclusion was that even 2 millimeters and 2 degrees of change in the knee in your bone cuts can make a significant difference in the intercompartmental pressure. Now, if you compare that to the accuracy of our saw blades, the current saw blades that we use could make a 2 degree change without even getting recognized, and that's not even considering the standard deviation. Also, some of the saw blades are thicker. Some are even 1.5 millimeter thick. It is not precisely possible manually to make perfect cuts with this kind of instrumentation. And that's where also the technology comes into it. So the value of technology, it gives quantitative live feedback so we can avoid, contain, and control the error before it starts the domino effect and affects our outcomes. Also, we should be able to make accurate and precise cuts. The technique should be reproducible. And if we want to chase new targets for alignment, like a 3-degree Varus target, we cannot do it without technology, or cannot do it reliably without technology. So that's the reason why we need technology. Now, looking at the utilization of technology, this data is based on a report from the Orthopedic Research Network. It looks at different components and technologies being used in joint replacement. The last report that came out, actually this year's report, it has a section on digital assistance. So they categorize all the technologies as digital assistance and quantified how many procedures actually needed use some kind of digital assistance. So the leader of the pack is partial knee replacements. Between 1 out of 4 to 1 out of 5 partial knee replacements in the US was done with some kind of digital assistance. Most of the times it was one and not a combination of multiple. The immediately following that is knee replacements, where about 1 out of 10 knee replacements was done with at least some kind of digital assistance. Hip replacements lag much far behind that, but they're also catching up. So in short, there is a progressive increase in the use of digital assistance. So we don't want to be just left behind. We do want to learn these techniques so we can use them properly and make better surgery and give better patient care. They categorize the soft tissue balancing devices. Actually, they categorize it incorrectly. The VeraSense or the orthosensor, which is microelectronics in a disposable tibial insert, that is the leading device for soft tissue balancing. They incorrectly categorize knee align, which is based on sensors, but it is not assessing soft tissue balance. It's actually assessing the orientation of the cuts. But that is also a really leading device, followed by the Zimmer Biomet's Eye Assist. If I had to accurately categorize the soft tissue balancing devices, the conventional one would be with spacer blocks and laminar spreaders. Second would be tensioners. Third would be pressure sensors. And fourth would be gap measurement based on cuts in robotic knee replacement. So this is the conventional balancing, where you see the cuts made, the laminar spreaders are there, the bony landmarks are marked, the white side line is marked, and we are manually assessing the tension and feeling for the gap. This is the classic method. This has low accuracy. It is not very quantitative. It's just basically a qualitative assessment. Even though there are numbers on the spacers, it's not really very helpful. But at least it's better than not doing balancing, which hopefully you don't do. This is widely available and has no cost associated with it, which is a big plus for this. Next in line are tensioner devices, which are quite reasonable, where they measure the tension and the gap. And this is more quantitative, so it is more accurate in terms of avoiding a domino effect, where you can actually find out what the problem is, which variable is going wrong, and try to correct that. These are available, but you'll have to push for the availability, but you can make them available. Some of these devices, like the device that is shown in this picture, is currently not in manufacturing, because I guess the companies are manufacturing robots and computer assisted technologies. The next one, this is state of the art. This is a pressure sensor. This is microelectronics like is in your phones, that has been compressed and put into a disposable tibial insert. And it is after making the cuts and after making your trial implants, then you place this device in place and you get feedback on what is the actual pressure in each compartment. And based on that, then you modify your releases, modify your cuts, change the component sizes or component position, and try to get these numbers within 15 millimeters of each other. This can also be done with knee range of motion at 10 degree, 45 degree, and 90 degrees. And ideally, all three positions should be balanced. One of the designers of this technology is at VCU, so I have had first-hand experience with him and have seen him balance it. It's a very neat technique, and the amount of intraoperative modification that he does for this is just incredible. I mean, it's really very good surgery. I really like this one. The benefits is that it fits your actual workflow, whatever it may be, gap balancing, measured resection, whatever way you do it, it's not going to get in your way. There are no markers, there are no pins, and it gives you interoperative feedback. You can customize that to make your soft tissue releases and refine your component placement. And it is amazing how small changes in component placement can alter the pressures. And we just cannot get that feedback manually. They have done studies where they very precisely balanced the knees and then followed the patients, and their outcomes were very good and improved compared to conventional balancing. However, in real life, when you're not balancing it with that meticulousness, those effects are probably not going to be produced. That probably would be apparent in long-term data. So meticulousness is something we definitely need in doing knee replacement. And this just shows that. One of the problems is that you can make a wrong bone cut and go on balancing the knee and still have some degree of that domino effect. Also, this does not actually tell you if the component size is wrong directly, or also doesn't tell you actually about the rotation, but you can make small changes in that and see the effect on knee balancing. The insert itself is single use, so it does involve some cost, but it's not like $1 million like buying a robot. Uh, Currently, there is not enough long-term data for this. Now we move on to technology for alignment and bone cuts. The established one is the conventional manual jigs. Then you have patient-specific instrumentation and implants. Then you have accelerometer-based navigation. You have computer-assisted surgery, also known as optical navigation. And finally, you have robotic knee replacement. And we'll explain each one of them in detail. So the first of all, the conventional jigs. This is referencing based on anatomic landmarks or the intramedullary canal. The cutting jigs are placed off of those landmarks, and drop rods are used to check your alignment. This is the commonest use, is cheap, accessible, comes in every set. However, the accuracy is pretty low. One study found that the accuracy for tibial cuts is 68 to 72%, kind of close to what Dr. Insal thought about 30% of the cuts being out of 3 degrees, having outliers. So the accuracy was similar. Next in line are the patient-specific instrumentation and implants. So this is based on the premise that you get a CT scan or a MRI and make a customized guide and an implant for the patient. So of course is expensive. Currently in the custom cutting guides, the Signature from Zimmer Biomet and Visionaire from Smith and Nephew, these are the market leaders. Also for custom implants, Zimmer Biomet has a big share, but Conformis is the current market leader. So like I said, we get a preoperative CT and MRI, which is an additional cost. Then there is some time lag where the data goes to company, they make the implants as well as the instruments. One unique thing about this is that you can make the perpendicular tibial cut, but still have a native joint line, because the component doesn't have to be symmetric. It can be made asymmetric where the joint line is still 3 degrees. And because it is done with machines, is more likely to be accurate. So that's one unique thing about the custom implants. Also, the implants have a better match because they are based on 3D printed models and 3D data. So the sizing is supposed to be more accurate. They are also designed so that the cuts would lead to improved balancing and less need for releases. But a lot of this has proven to be mainly theoretical. Even though there are less instruments and supposed to be less over time, this hasn't actually been proven in more, I should say, better study designs like meta-analysis, randomized control trial, large-scale studies like registry studies. The benefit of this technology has not been proven. So this has relatively gone not out of favor, but less in favor. This is another one, accelerometer based navigation. The accelerometer and the gyroscopes like we have in our iPhones, these can be placed in a handheld portable device that can be attached to tibial or femoral cutting jig, and that can guide you on the orientation of your cutting block. The hip, knee, and ankle centers are calculated with motion. This has pretty significant use in the current market because it's portable and doesn't have capital expense. The benefits of this is that this allows navigation of the proximal tibial and distal femoral cut, not the anterior posterior femoral cuts, not the rotation, not the size. But in those cuts, it has accuracy very similar to full navigation. And the OR time is also less compared to full navigation because you're not putting those pins, you don't have the camera and all that stuff there. So it's relatively quicker, and that's why it is getting a lot of favor. Also, we're not violating the intramedullary canal, which is the source of significant blood loss and also the source of fat embolism. So those are additional benefits. Also, a preoperative imaging is not needed, so there is no additional lag time, radiation, cost associated with that. The problems are is that does not give feedback on AP femoral cuts, the implant size and position. Now, the computer-assisted surgery, as we proceed further, these are more full-scale products that give far more feedback than otherwise. In this technology, there are reflective spheres or reflective beads that are attached to these arrays, which are fixed to pins on the femur and the tibia. The system sends infrared light that is reflected from the spheres that is collected back by the camera. Based on that, the computer calculates the three-dimensional or spatial orientation of the pins as well as the cutting tools, and this is used to provide live feedback during surgery. It has been proven to have improved accuracy in the coronal alignment, in the coronal cuts, as well as in femoral rotation. The sagittal cuts have somehow not proved to be more accurate compared to conventional instrumentation. The nice thing about this is it also gives feedback on the size of the bone gaps based on the tibial and the femoral cuts. This also does not use an intramedullary guide, so blood loss is less risk of fat embolism. However, long-term studies as well as higher quality studies have not found significant difference in patient function yet. Also, this does not quantitatively measure the soft tissue balance, the tension in the compartments like the orthosensor device does. There is direct cost uh, of the equipment. Also, the OR time is more because you are putting pins and are putting the arrays, spending time on registering bone and kinematically finding out the hip and knee center. So there is definitely increased OR time, and that indirectly increases the cost. Also, the femoral pin sites can fracture. The rate is about 1.3%. That is not a negligible rate, but it is there. Also, you can get tibial stress fractures as well. Next, we come to robotics in joint replacement. The current market leader, actually the dominant one, is Stryker with the Mako robot, about 82% utilization currently, followed by the Rosa from Zimmer Biomet, and then the Smith and Nephew and other robots. These can be passive, semi-active, or active depending on how much the robot does. Most of them are semi-active or passive. There is at least one that is fully active that has gone through FDA approval last year and has at least one published study for it. Uh, this is the Mako system, which shows the Mako robotic arm, the different stands and the software for it. This involves a preoperative hip to ankle CT scan. There is comprehensive planning of the knee axis, the component sizes based on the CT data. So this basically involves navigation and robotics. The navigation is optical navigation majority of the times. You get live feedback on the spatial orientation, the gaps, the component size and position. And the robot does milling versus cutting. Some robots have milling, some have cutting, depending also on the procedure. The partial knee replacements are more, I think, milling kind. The total knees are more of the cutting kind. The robot also gives haptic feedback. It has a defined territory where it wants to make the cut. That's where it will let you make the cut. If you deviate beyond it, the instrument is just going to turn off. That tactile as well as auditory feedback is thought to improve safety. The benefits, of course, accuracy is well proven in multiple studies. It gives the most comprehensive feedback. It also gets in the way most, uh, it adds to safety with haptic control. The problems are it, of course, gets in the way, changes your workflow, increases over time, very high cost, which is prohibitive in most of the circumstances. Also has a learning curve. The Mako company says about 13 implantations and you are good to go. Not sure if there is live data about it. Now, summary of utilization. If you look at this data that was collected last year, the Mako robot leads the others by a wide margin uh, in robotics as well as in overall. In terms of custom implants, Conformis followed by Zimmer appears to be the winner. In terms of cutting guides, Smith and Nephew is what is leading the pack, followed by Zimmer. In terms of soft tissue balancing, the ortho sensor is leading the pack, followed by the ortho aligned device. Now, this is a summary of what feedback we get from each technology. The conventional technology, you don't need a pre-op scan. You get qualitative feedback on bone cuts and alignment, also qualitative feedback on balancing, on rotation as well. The pressure sensors mainly give feedback on balancing and the designers say that that can be used to customize the rest of the things during the surgery. The patient specific instruments and implants rely mainly on the built-in nature of the implants and instruments for rotation, as well as the cuts. The accelerometer based navigation gives feedback on the distal femoral and proximal tibial cut. It does not give feedback on rotation, on balancing, and it does not require a preoperative CT or an MRI. The optical navigation gives the most comprehensive feedback, similar to robotic total knee replacement. The difference mainly is the robotic knee also lets you execute that same plan. The optical navigation lets you execute it. So there can be some error factor there as well. In summary, there is a rapid rise in technology used in knee replacements. Many technologies that appear promising have not proven effective. Cost is a major barrier. Also, optical navigation and robotics are the most comprehensive solutions to date that give the maximum feedback in different parameters. The accelerometer-based navigation and pressure sensors are new additions with a lot of promise in certain areas. And that's my email address. And that's it for today's presentation.
Thank you, Niraj. Fantastic presentation, very up to date, and very much evidence based as well. Just a few questions.
Yeah.
Niraj, we always talk about getting the perfect alignment, isn't it? So,
Yes.
with the conventional, I mean, a large percentage of people would still do conventional knees, and there's a lot of data to say that the overall functional outcome or the long-term outcome at 10 years, there's not much of a difference between a computer navigation and a conventional knee. What is your take on that?
So that is correct that this data exists and is in a large volume, large enough that it cannot be ignored. The downside of this data is the outcomes that we are assessing. These are outcomes that are far from long time back. So these outcomes are probably not, they cannot differentiate enough between the two. That is my take on it. It's not just that there is no difference. We are probably not able to detect the difference.
Thank you, Neeraj, for that. The other question is, you mentioned that almost, if you look at new technology, the Mako Robo accounts around 83% of new technology. And what about the geographic distribution? Where are these new technology implanted the most? Is it entirely the United States, or how is it distributed?
So
Is there any data on that?
So the data currently that I have, that I presented, that is for the North America, including Canada and the US. There is a lot of a lot of robotics implementation in Europe as well, and a lot of innovation actually is over there. I guess our IRBs are more strict and stuff like that. But I think that it is not just the US, it's also the European countries, and even developing countries. There's a lot of emerging data from there.
Thank you, Neeraj, for that. The other question is regarding the stress fractures that you see with the navigated knees. I remember that whenever you put those drill holes to put the arrays, there's an option to, you can just take some of the chamfers and put it, chamfer cut bone and put it there as a bone graft. Do you think that's a very good technical tip so that you can reduce the incidence of late stress fractures?
I think definitely so. Yes. The other part of it is I did not present that there, but there is something called as a limited navigation where you are not, where just like you use that ortho aligned device, which has just the handheld part of it. So rather than putting those spears on the bone, you just put it on the jigs. And that can give you some feedback. And there is at least one paper that says that the accuracy is pretty good. I mean, it is not as comprehensive feedback as the optical navigation gives, but it is fairly accurate. So yes, definitely your technique of bone grafting that area and being careful about how you place it is definitely helpful. But there are also ways to avoid that.
Thank
And
you,
that
Neeraj, for
also
that.
concerns me when I look at the recently the FDA approved one that is a completely live robot. it has far more pins than those 2 pins in the femur and 2 pins in the tibia. So it would be interesting how that turns out.
Okay, that's interesting. Thank you, Niraj. Just one last question before we wind up this one. What is your take on uh, robotic decay? For example, do we really have the tactile feedback? For example, when it goes towards the neurovascular structures, for example, you're doing a valgus knee, and there's always a risk of an injury to the common peroneal nerve. Do we really have that kind of tactile feedback when you really do these robotic or macro knees?
So the thing to consider here is that bone is static, but soft tissue is not. So the distance of these neurovascular structure changes based on the position of the knee and different contractures and things like that. And that the robot cannot assess. The robot is only going to tell you that you are at the end of the bone. It's not going to tell you how close you are to something. And I think
And
that's only a
yeah,
relative benefit. And we are still retracting the tissues, we are still retracting the ligaments and stuff like that. So I'm not sure if that is a game-changing thing.
okay. Thank you, Neeraj. I think that's all the questions that we have for this session. Fantastic lecture, really cutting edge. I'm sure this is going to benefit a lot of people all over the world. Thank you very much for joining in.
Thank you. And if you have any questions or any clarifications, you are welcome to email me.
Thank you very much.
All
Bye-bye.
right. Thank you. Bye.